In this video, I will review the neurological exam, looking at possible pathologies and their clinical correlations. The first assessment of the patient is their mental status. Each of these realms should be assessed as you complete every encounter with a patient as you take the history and perform the examination. When you report both written and orally, you want to use the verbiage in this chart and avoid the generic term, altered mental status. A mnemonic for treatable causes of changes in mental status is AEIOU TIPS. This video is of a patient with schizophrenia, displaying tangential speech.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there's either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime, when I be outside in the sun, I used to show my friends things that they hadn't seen before, like the halo. See, like the halo, when I was 19, when I was a preacher, and I had my trial sermon, I used to see a little light over my shadow on the ground in the daytime. And then now, ever since then, there's like a light coming further down over my body, around my shadow. It's over my body, but around my shadow, and I see the light, which is your halo, I mean your aura. And that's why everybody can't see that. But if you see, you got something to do with the drugs too, we say. And now I don't know what's for real. I know what I see, but I don't know if it's for real or not. And so that's why you say people are different. And see, like that anointing, like see, like sometimes when I come outside, I can see when I look at the trees, the wind starts blowing. Cause we know we get oxygen from the plants, and we get them carbon dioxide. And so it's the wind usually blows sometimes, but it don't blow all the time. Like when I'm in the house a long time, it blows real strong.
In this video, a patient with bipolar describes manic episodes with disorganized speech.
Hey guys, so I'm like fucking crazy as shit right now. Like I don't know if it's because like I want to put my meds, but I'm actually kind of rapid cycling right now. Like I was having all those like racing thoughts, and like now they're like getting a little bit better, but I feel really crazy, and I just can't think. I can't concentrate. I'm like really paranoid. Like I do not want to go to a freaking like mental hospital ever. Like I don't know. I think I'm crazier than my psychiatrist even sometimes. I don't know. I'm just like really fucking paranoid that she's gonna like make me go to a hospital, mental hospital, even though I like wanted to before. But in the past, like so bad. Like when I was having hard times and stuff, like I was trying to get in to see the psychiatrist for the first time ever, and it was taking so long. Fucking insurance sucks, you know, like they only go, I don't know, whatever. And so I was just, I don't know, I was so desperate. I was like, I don't know, I've got to go to like freaking Broughton or something. Like crazy house, gotta go there or something. But somehow I made it, luckily. I don't know, and I talked to her about it, like how I was like really manic in like October and the beginning of November, and like I just did a lot of crazy shit, and you know, she just told me, you know, like amygdala and stuff, like the mood stabilizers like help, and you know, they're supposed to like help you from cycling as much, I guess, but it still happens. And she said, you know, that's normal, it still happens, I'm just gonna have to basically get used to it, I guess. But I don't know, like, it's freaking crazy. Like, I'm talking to, like, somebody that I guess, I don't know, I'm not sure if they're, like, a YouTube subscriber, but they had watched some of my videos or something and, like, messaged me on Facebook, and they're really nice. Shout out to Canada! But, like, right in the middle, I'm like, I'm actually having racing thoughts right now, because we were talking, and, I was like, I made a video, and then all of a sudden I'm just like, I think I'm rapid cycling. I'm like rapid cycling now or something. It's not that bad, I don't think, right this second. I just noticed that our cat Thresh, son of Aurora, has been chewing on my little hook thing for my sleeping bag. That little shit. So I don't know. I don't freaking even know what to say. Like I don't know. Definitely been having weird things lately, like needing an uppage on my medicine. But it worries me because I was like, well, how much Lamictal a day can you take? And like, I don't know. Like, maybe the maximum dose isn't even enough for me or something. My mom's crazier than hell. My birth mom, she's crazier than hell too. Pardon my language. I don't know, I've noticed I cuss a lot more when I'm having problems. I don't know, it's like I just can't filter it as much or something. Actually, I do have a potty mouth. Like, really, really, really bad in real life. Like, so bad that my husband, who was in the military and has a potty mouth, goes, shh, at me sometimes, because, like, I'll be crazy cussing or I don't know, like, and I don't know, like I don't even notice. So they put me on a new medicine today. It's actually an antipsychotic. It's called like Trilofon. And what I found so interesting, because I do not want to take it, like, it has scary side effects to me. I'm like such a hypochondriac. But it is also used to treat severe hiccups and extreme nausea and vomiting, which is online. You can find that online. That's where I found it. I think it was like drugs.com or rxlist.com or something like that. I just searched the medication name. And just got a cold chill. But one of my things is like when I get really nervous or just when my thoughts are racing or sometimes even when I'm rapid cycling, like my stomach just responds to everything. It's like, I hate you. You know, just like, I don't know, like, you're nervous, puke. You woke up, puke. You're sad, puke. Your thoughts are racing, puke. Like, I'm just a very pukey person. So I'm just like, maybe this will help my pukiness, you know? Because like it said it, I guess it was in the same class as promethazine, which is Phenergan, which I guess a lot of the enes, I-N-E, like diphenhydramine, which is Benadryl, or like doxylamine, that's Unisom, and promethazine, Phenergan, I said that one already. Like, I guess they're kind of all like antihistamines and antiemetics, which means they help you. Antiemetics are just medications like Phenergan that keeps you from like, it helps nausea and vomiting. Like they're used for Dramamine, that one as well. And you know, they can all be used, I guess, kind of for nausea and vomiting and motion sickness from my understanding, I guess, like from what I've been told or what I've read, you know. Don't ever use anything, of course, without talking to your doctor, but like, I don't know, it's kind of awesome because, you know, I even tried it, like I was sick at my stomach and I took a Benadryl and it actually made me feel a little bit better. But again, you know, it has a sedating effect, so it could just be that it sedated me a little bit and it calmed my nerves down or something because I was sedated. And anyway, like so freaking depressed. Like 2 or 3 weeks ago, I was having really bad kind of suicidal ideation for like, you know, a moment here, a moment there. It kind of lasted longer than it ever has. It kind of worried me. You know, of course, I talked to my psychiatrist about all that, my therapist or whatever. But No, I just don't want to freaking take a lot of medicine. But I don't want to be crazy. I don't know, so, you know, like my Canadian friend that I was talking about earlier was talking about just like, you know, about electroconvulsive therapy. We were talking about that or something. And I'm just like, I'm interested in talking to my psychiatrist about that now, because he said it was like kind of like a defibrillator to the brain. I don't know, something like, I guess maybe it resets your brain or something. I would be willing to try that. Yes, electrocute my head. I don't know. I'm totally willing to try it, I think. Or I'm almost there. Like, I'm just so tired. And I've been getting angry. Like, I'm not an angry person typically, but, you know, like, I've just been, like, the stupidest things were making me mad. Like, really mad, like, really fast, just, like, mad. And I'm like, okay, this is unreasonable. This is nothing to be mad at someone about. And I don't typically say anything. There have been times when I was really freaking manic that I have said things. But I'm a very passive person, and, you know, like, never been in a fight, and, you know, I was raised by my great-grandparents and stuff, like, I don't know, just different. I'm just freaking different. I don't know, like, as soon as I, like, I don't know, I just can't think. Maybe my racing thoughts are better. But, so I guess I was rapid cycling, and now I'm kind of more depressed again. Just rapid cycling, but whatever. I want to try to catch, I have these episodes where I'll go from, like, literally crying to literally laughing my ass off. I really want to catch one of those for you guys. So, anyway, the next time I'll try to catch it sooner, because I was way more freaking weird a few minutes ago. But, yeah. So, thanks to all my friends out there, like, in real person and on the internet and via YouTube. I get, like, tons of messages, like, it's really nice, you know, to, like, kind of have that community. I try to keep in touch with everybody and, you know, be active, but, like, sometimes it is hard, like, even though it's, like, the internet and, you know, I don't even have to, like, face anybody or go outside. It's just, like, hard sometimes. I don't know. It's like you don't even have the freaking will. Like, you don't care about anything. Like, to even do it. Like, I don't know. I was, like 2 weeks ago, I was so depressed. I was just like, I'm just gonna freaking delete my YouTube account. Like, I'm not helping anybody. It's so stupid. Like, blah. Whatever. You know, and my husband's like, you really like it? You've been doing it for a long time now? And, you know, that whole, what I've said, if I can just help at least one person, it'll be worth it. You know, and I want to freaking help get rid of the fucking mental stigma. Like, oh my god. I don't know if it's like this everywhere, but in the USA, freaking people are so mean to crazy people. Delia, come here. Or, you know, just not saying people are crazy or whatever. But, you know, if you have bipolar or something, you know that you have those moments you just freaking feel so crazy. So, like, and tons of other stuff too, like other disorders, I'm sure feel that way too, but, I completely freaking forgot what I was saying. Damn, I feel like that was really something I wanted to say to, see, what was I talking about? I was talking about almost shutting my YouTube account down. So I'm really glad I didn't. Obviously. That would have been really dumb. But, and, like, really defeating of the whole point of this. But I don't know, I was just fucking feeling really depressed and whatever that day. Like, way depressed. Like, don't give a shit about anything. Like, want to get rid of all my stuff, don't give a shit about anything. Like, Anyway. The fuck was I gonna say? Oh well, so anyway, I guess I'll put this on YouTube and see if it helps anybody. I guess I'll talk to you guys later. And if you watched all of this, thank you. Hope it helps you or someone. I know it really sucks to not only be bipolar, but it sucks for the people around us, and we know that. Even if we can't help it sometimes, we know that. And we're very thankful. I'm speaking on behalf of all bipolar people. Just joking. Alright, so I guess I will talk to you guys later. Or tomorrow, or some other time, or whatever. Alright, bye!
In this video, a patient with bipolar describes her depressive episode.
You know, everybody always wants to know what it's like to have bipolar disorder. Or they don't understand it, or it doesn't make sense that we can go so quickly from being okay to not being okay. Whether it's mania or depression. Honestly, I don't even know what I am right now. I was sitting here working, had my earbuds in, listening to the doctors. And some thought of I don't know, New York popped into my head. I don't even know why. And that went to me thinking about my kids and my oldest daughter, Andrea. And our trip in August that we took up north for Soul Fest in New Hampshire, and we visited New York City for the first time, and it was great that we got to do that. I just wish that I wasn't such an idiot. I mean, it had been a better trip for her to remember my son. Because I got real irritable because I was in pain, and I started thinking about the fact that I called everybody dumb the day we went to New York City. And I know that sounds like something really stupid to get upset about, but my daughter takes everything to heart like I do, and I told her that day that I was sorry and to not take what I said to heart, and she told me she does, you know, and I don't think my kids are dumb at all. Far from it. I think that my kids are smarter than I've ever been. And so, this is what bipolar disorder is like. You have thoughts that go from one to another that you can't stop the progression of, and now I just feel like such a horrible mom, and only 2 of my kids are speaking to me. The other 2 aren't. What you're seeing is not a pity party. It's not self-pity, and this is just what I go through, and I'm by myself. I just look back and it's like I live a completely different life. Like, that wasn't even my life. And I should have never been a parent. I should have never even had kids. They don't deserve. I don't deserve them. I don't deserve them at all. And so, maybe me being non-existent is exactly what I deserve. I don't know how to fix anything. I don't even know how to fix myself. So, you know, everybody who thinks that bipolar disorder is a joke, you don't have to understand. I just randomly decided to record one of my little mini depressive breakdowns, so that maybe you could at least see that it's not something that we can just snap ourselves out of or control at will. I wish I knew how to turn my brain off right now. And I still have 4 hours of work left to do, and I'm gonna try to concentrate on that. Instead of wanting to sit here thinking of ways that I can make things up to my children. Because the fact is, I can't. Welcome to manic depression.
This video is of a patient with auditory hallucinations.
Hallucinations. Hallucinations are false perceptions, indistinguishable from reality, that occur in the absence of an external stimulus. In this clip, you'll see a psychiatrist interviewing a woman with schizophrenia who's experiencing both third-person and second-person auditory hallucinations.
There's something else I'd like to ask about, which again you've mentioned before, which is that sometimes you're aware of someone or something speaking to you.
Mm-hmm.
Does that still happen?
Mm-hmm. Lots.
It happens a lot?
Mm-hmm.
Okay. Tell me about that and what you notice.
There are people talking about the people I've been telling you about.
Right. And what sort of things do they say?
They say that I don't keep my house clean.
Mm-hmm.
And that's why I haven't got any friends.
Right.
That they don't like me.
Mm-hmm. But they're quite unpleasant things that are being
Mm-hmm.
said to you.
Mm-hmm.
Or are they said to you, or are they said about you?
More about me.
So from that, do I understand that the voices talk to one another?
Mm-hmm. Mm-hmm.
Right.
Mm-hmm.
Are they male or female?
Male. Men.
And where do the voices appear to come from?
Different places, but around me.
So
Usually where I can't see.
somewhere outside in the room
Mm-hmm.
where you're not able to see anybody? Okay.
Mm-hmm.
Okay. Do they stop you from doing anything?
If they tell me not to go out, I don't go out.
Okay. Do they ever tell you to do anything else that you wouldn't normally do or that you feel you shouldn't do?
No, they don't tell me much, no.
Okay. Do you hear any other types of voices in addition to these male voices that talk to you and about you? Are there any other voices that you hear at any time?
Mm-hmm.
What are they, or what's that one like?
That's different. That's quite a nice person.
Okay. And does it, apart from saying nicer things, is it any different in its character to the other voices that you hear?
It's a lady.
Right. So very distinct from the other voices.
Mm-hmm.
And whereabouts does that voice seem to come from? Is that from sort of outside, around you in the room?
It's in my head.
Right.
Near it in my head.
And every time you hear that voice, does it seem to be coming from within your own head?
Yeah.
You said that it says nicer things. Could you give me an example?
It tells me that I'm all right.
Mm-hmm.
And that I shouldn't always listen to what the others are saying.
Right. Do you find that comforting or reassuring?
Mm-hmm. Mm-hmm.
Okay.
This video describes a patient with an abnormal olfactory sense. In PD, we do want the patient to close their eyes. Loss of smell is nausea. The most common cause is an upper respiratory infection. Other causes include allergic rhinitis, trauma, meningioma affecting the olfactory tract, and Kalman syndrome.
I have two containers that have certain substances that we'll see if you can identify. First of all, can you include your right nostril? Can you smell anything?
Didn't smell.
But can you identify it?
No.
Okay. There's another container. Can you smell anything?
No.
Okay. Let's go ahead and include the left nostril, and that's just the right nostril. Can you identify or smell anything?
No.
Okay. And now, can you smell anything in this container?
No.
Okay. This container had orange fragrance, and this one had coffee.
This patient's visual acuity is being tested, and he is demonstrating decreased acuity due to optic nerve damage.
I want you to read the smallest numbers that you can. Which line can you read the smallest?
6, 7, 4, 5.
Okay. Can you read the smaller line?
No.
That's the smallest line you can read. So you're reading the 20 over 70 line.
Yeah.
Let's go over here. Can you read the smallest line? Which is the smallest line?
4, 2, 8, 3, 6, double, U,
Okay.
E, M.
Okay. So Can you read the next smaller line?
No.
So I was reading at 2040. Okay, thank you.
This patient has a right-sided hemianopsia from a lesion between the optic chiasm involving the left optic tract, radiation, or striate cortex. This patient has an afferent pupillary defect of the left eye.
This young man has a resolving optic neuritis, and you can see that he has an afferent pupillary defect on the left. We're putting a small filter over the right eye to try and balance that defect, and you can see that when the light is shined in the left eye, there's still a dilation, indicating that there's not enough filter placed over the normal eye. Now a 0.6 log unit filter is placed over the right eye. And again, you can see that it's not quite large enough to balance this defect. I want to point out that in between each testing, what you need to do is to re-bleach the amount of light entering both eyes, as I'm doing here, and that's to prevent any asymmetric bleaching of the eyes while the filter has been placed over it. We're getting close.
This patient has ocular myasthenia gravis. Note the bilateral ptosis.
Here's the baseline exam. There's bilateral ptosis, and you'll see that there's bilateral duction deficits as well. The patient is apparently fixating with the right eye, and there's a left hypertropia, but the vertical ductions of that left eye are impaired as well.
Note the incomplete abduction of this patient's left eye from sixth nerve palsy.
Open your eyes wide. Okay. All the way over, all the way back, all the way over and up, and down, coming back, and over. Okay. Look over here. Quickly look over there. Okay. Quickly look over here. Yeah, come on back.
Note the inability of this patient to adduct both eyes. This is bilateral internuclear ophthalmoplegia. In this video of a patient with progressive supranuclear palsy, note the abnormal eye movements.
Look here in forward gaze. All of these saccadic intrusions are not nystagmus. They're actually square wave jerks. There's a fast phase that takes the eyes off of the target, and another fast phase that brings the eyes right back to primary fixation. And this differs from nystagmus, which have an initial slow phase. So these are actually saccadic intrusions. Now watch pursuit. Pursuit is a little saccadic. It's not smooth. Now we're going to show you saccades. Little slow, little inaccurate. But again, you can see fixation is disrupted by these continued square wave jerks, these saccadic oscillations. They're called oscillations when they're relatively continuous and intrusions when they're intermittent. Now here we're showing that the patient with doll's head maneuver actually has a fairly full vertical movement of the eyes.
This patient has neurosyphilis with Argyll-Robertson pupil. Note the accommodation with convergence, but no reaction to direct or indirect pupillary reflex.
We'll have an Argyll-Robertson pupil in a patient with neurosyphilis. You see, with light being shined in either eye, there's minimal, if any, constriction of the pupils. Not a very convincing light response, but look how small those pupils are to begin with. That's characteristic of an Argyll-Robertson pupil. Now what we're doing is turning the light on and off, and again, I don't think there's any convincing pupillary response. What we're going to do here is to ask the patient to look at the finger as it approaches his nose, evoking his near response. Now look, those pupils are constricting to near. What you can see is when he looks off in the distance, they dilate, proving that they were constricted to near. Here we go again. Watch those pupils. I think you can see them constricting a bit.
This patient has loss of light and sharp touch discrimination.
So you feel better on this side. This side would be normal.
Exactly. Around my eye, I feel very well on the right side.
And how? But this is different here.
It's different.
Here,
it's different.
and here.
My skin feels like sunburnt.
Okay. I'm going to have the sharp object. Does this feel sharp here?
Yeah.
And here.
Yes, it feels sharp.
Any difference there?
No.
Down here,
no.
Down here, the same.
Same.
Totally normal.
Yeah.
Okay. How about over here?
Feels numb.
Okay, different. It doesn't feel as sharp there.
It feels sharp, but as if the skin had been numbed with drops or shot or whatever.
Okay. And is there any difference here versus here versus here?
This side is a little. It hurts a little bit more.
Okay. You tell me when it changes, okay?
Okay.
Sharp.
Sharp. Mm-hmm. Sharp. It goes numb. After the eyebrow, it's sort of.
Just over the ear.
It leaves me a feeling like you had just touched it with something very hot.
Tell me when it changes coming across.
Yeah, after the nose, it's numb.
There.
Yeah, it starts.
Tell me when it changes here.
It hurts on the red side of my lip. It hurts.
Okay, so say now as soon as it changes.
Now.
This video has patients with cranial nerve 7 deficits. This patient has conductive hearing loss on her right side.
Can you hear that there? Hear it over here? Harder to hear over there? Okay. All right. Can you feel it in the middle or to one side? Feel it over there? Okay. All right. Can you feel it back here? Okay. Tell me when it stops. Can you still hear it? Okay. Tell me when it stops over here.
It stopped.
Can you hear it? No. Oh.
Note the uvula deviating to the left. Note the absent gag reflex. Note the tongue deviation on protrusion.
So you got your tongue all the way out. And again, we're just gonna and then all the way out as far as you can. See if you can get all the way out of your chin here. Good. I want you to move your tongue over here to the left, to the right side. I want you to move over to the left, over here again, and over here again. Okay. And I want you now to stick it all the way out. And I want you to push against the tongue blade. And I want you to push over here. The other side now. All the way over here. And only push it back. Push it back. Okay, and over here again. Only push it back. Push it back. Okay, good.
This patient has MS and demonstrates several neurologic findings, including increased muscle tone, absent Babinski, and increased deep tenon reflexes.
Thank you very much for coming. We really appreciate that. I'm going to examine your legs, Siobhan, okay? And I'm going to move you around, but don't let me hurt you at all, okay? Now, normally in an exam situation, I'd probably expose a little bit higher up on the leg, but at the moment, we're just going to roll up your jeans to this point. Yeah. So the first thing I'm going to look for is wasting, or fasciculations, or jumpiness of the muscles, if you like, and look for pes cavus. And I don't see that, so there's no pain in the legs at the moment, Siobhan, is there? No. I'm going to move the legs around a little bit, and then I'm going to pick them up fairly smartly. So you can see that the leg is quite stiff here. I'm going to pick it up there. And most legs will bend fairly easily in the middle, but Siobhan's are a little stiff, but they're better than they were. Then I'm going to check, while I'm here, for clonus. So I make a right angle at the knee and a right angle at the ankle, and I gently, gently give it a little flick. And as you can see here, it goes into a little bit of a spasm like that, and that's classic clonus. Am I hurting you?
No.
Great. Okay, well that's fine. And you can relax that down and it'll stop in a moment. Similarly here, it's a bit stiff, the leg. And there's a little bit of clonus, but not maybe as pronounced as the other side. Okay? Yeah. Okay, I'm going to relax that down. Thanks. So if the tone is increased, I'm assuming this is bilateral. These are bilateral changes. And my assumption is, I know Siobhan well, but that this is a paraparesis. But to prove that, I'm looking for some weakness. So can you lift your right leg straight up in the air, just like a ballet dancer? Keep it up there. Don't let me hurt you now. Okay, well done. Now push it down straight into the bed. Keep it down. Don't let me lift it. Well done. Can you bend up your right knee? And keep it bent. Don't let me straighten it. Oh, good. And now kick it out straight. Go on. Okay. Now with your right foot, can you cock it up this way? Cock up your foot to your head. That's it. Keep it up there. Keep it up. Tiny bit weak there, but not too bad. And push me away with your foot, pointed out to the wall. Down that way. Good. Keep it pushed out there. Well done. So the power is actually very good. It's just the coordination. The stiffness is there. Let's check coordination. Can you take your heel, Siobhan, and I want you to lift it up and place it on the side of your knee and then run it down your leg and then bring it out and do the same again. So in your own time. That's it. Down the leg and down, then out to touch my finger and then start at the top again. There you have it. And again. So a little, you can see there's a mild ataxia there. And then I'm going to do the reflexes. Okay. So I'm going to bend up your knee a little. I'm looking at the muscle group here, and this should be quite brisk. And the same again here. Should be brisk because we know there's increased tone, there's clonus, and there's incoordination. Okay, with your right knee, can you bend it up? It's best to break the instructions into component parts, and can you flop your knee out towards me? I'm going to take your foot and relax it as much as you can. That's perfect. And I'm going to give you a little tap. You can see I even offset clonus there. Thank you. Same again on the left side. Up and away. Well done. You know what you're doing. And it's a brisk reflex. Okay. Now, as I always say, the horrible thing is a little scratch of the foot. I'm expecting both plantars to go up because I've got increased tone, increased reflexes, clonus. So I take your foot gently, and I'm starting on the outside of your foot there, and I'm going to bring this stick out along the side. And the first movement of the big toe is what I'm looking for, and in Siobhan's case, it goes up very, very rapidly. So you can see it goes up rapidly, and you don't really need to go the whole hog after that. Similarly over here. You okay, Siobhan? You all right? For students, you should always keep an eye and reassure the patient and keep an eye on the patient's face in case you're inflicting discomfort, but she knows me well. Ready now? And again, the plantar goes up, the toe goes up, or an extensor plantar, very rapidly. One more time, Siobhan. That's great. So, I will test sensation very briefly with the tuning fork. Now I'm going to put this at the top of your neck there. Can you feel that vibrating? Yeah. You can, okay. Now I want you to close your eyes. I'm going to place this on your foot. Can you feel it vibrating there?
No. No. Yeah.
You can feel it there. Yeah. Okay, so some loss of vibration there, implying posterior column loss on the right-hand side. Now we do it on both sides, but for demonstration purposes, I just want to show the techniques. The next thing I'm going to do is I'm going to take hold of your right big toe, okay? Now, I'm going to explain to you that that is up and that is down. Yeah. Okay, close your eyes now. Can you tell me where it is now, up or down?
Down.
You sure? Where is it now?
Down.
One more time.
Up.
Maybe one more.
Down.
Good, okay, so proprioception is actually okay, but vibration sense is reduced. The next thing I'll do is probably do pinprick, but I won't use a pin, I'll use a toothpick. And again, not too sharp, I'm gentle sometimes. Can you feel that?
Yeah.
That's sharp. Is that sharp?
Yeah.
It's not meant to be too sharp. Close your eyes now. Can you feel me touching you there?
A little bit. No, yeah.
Yeah?
Yeah.
Okay, I'm trying to be gentle. Is that similar to the one on the top of your chest there?
No, not as much.
Okay. And as I come up, is it the same as the chest? Or is it less?
About the same.
About the same. Yeah. And over the other side, can you feel that there?
No.
No?
No.
Tell me if it changes.
There.
There.
Yeah.
Okay. From a motor perspective, Siobhan has a paraparesis, or a stiff or a spastic paraparesis, the differential for which is very wide. From a sensory perspective, she has some loss of vibration sense to the level of the knee on both sides. Proprioception is normal, and a variable pinprick sensation, but I'm not buying that it's a definite sensory level. And so the differential, as I say, for spastic paraparesis in a young woman is wide. But in Ireland certainly, and the UK, the most common cause would be a demyelinating disorder, or MS. In an older population, you'd think about things like cervical spondylosis, or indeed motor neuron disease, where it'd be motor signs only. The other differential is if you've got knee jerks that are brisk and ankle jerks that are absent with upgoing toes, that usually implies posterior column involvement, and that's things such as subacute combined degeneration of the cord due to B12 deficiency, or tabes dorsalis due to syphilis. If there's pes cavus, another example would be Friedreich's ataxia could mimic these signs with absent ankle jerks and present knee. And in different parts of the world, tropical spastic paraparesis, and you can also get hereditary forms of this condition called hereditary spastic paraplegia. Okay. Now, Siobhan is a little unsteady on her feet, and that's due to the fact that she's got cerebellar involvement. When you're looking for cerebellar involvement, when talking to Siobhan, her voice seems normal, but there can be a little staccato, and this is a typical cerebellar voice. We'll discuss that in a moment, but the other signs you look for in cerebellar disease are nystagmus in the eyes, as follows. If you look at my finger here, and at rest you look for square wave jerks, and then you look to your left, please. Hold that there, and you can see some nystagmus there, and to your right, and to your left. A few beats of nystagmus. I wouldn't overcall it. It could be physiological, but I think in the clinical setting you can call it. Can you put your hands out straight in front of you, please? Spread the fingers wide and close your eyes. I'm going to ask you to keep them there. I'm going to tap one of your hands. Keep them in the same position, okay? Good. There's a little bit of overshoot there. Open your eyes now, and in your own time I want you to touch the tip of your nose with the tip of that finger. Keep your eyes open now. Eyes open. Sorry. Touch your nose and touch my finger. Touch your nose, finger. I'm going to move my finger to try and catch you out. Nose.
Yeah.
To your nose, finger, eyes open. No, you're doing great. Nose, finger, nose, finger, nose, finger. So just a bit of intention tremor and slight bit of past pointing on the right, and then you do right to left as before. That's fantastic. And then she has some other cerebellar signs. Could you put your hands on top of one another like that? And just watch me first. I want you to take your right hand and turn it over like that. And now turn it backwards like that. Now up high and back and forth. That's it. Now you have it. So turn. Okay, not quite. If you just put right hand on top of left, and then turn it over, and then back. There you have it, back. Now, quick as you can. Now, up higher. That's it. Okay, that's great. Perfect. Okay, we're now going to examine Siobhan's walk, or gait. And Siobhan has a cerebellar syndrome, and you can see that she walks tentatively, I think would be a nice phrase of saying it. She walks with a wide base gait, tending to fall to one side, and hence why Roisin is protecting her. And with the feet together, we're trying to do Romberg sign. So, and with the eyes closed now, Romberg sign is not normally positive in a cerebellar disorder, so the implication here is that she also has some posterior column involvement or some vestibular involvement. Okay? So you hold the patient and ask them to stand on their toes like that. And then you look for a foot drop, and you run your foot under the foot like that. So there's no evidence of foot drop. Okay, so we might just ask her to walk away from us again and just leave her on her own this time. Well, no, we just keep her. Just walk normally if you don't mind, Siobhan. Just walk back and then turn around and walk back to us again. So that's the main portion of this. So it's a wide base gait. So she's holding her hands out widely to give her some sense of balance. But if you'll also notice that she turns, she's a little unsteady, so she must turn in a few steps. Come on back to us, Siobhan, thanks. And she also has a stiff gait. You can see the right leg is stiff, and she's swinging it out in a circumducting manner. So in addition to a wide-based cerebellar gait, turn around and walk away again, thanks. We'll have you exhausted yet. Sorry, take your time. As you see, the right leg is stiff, and it swings out to avoid catching the toe on the top. So that's what you'd see, for example, in the left hemisphere stroke with the right leg like that. But Siobhan has a spastic paraparesis with cerebellar signs. So this is a combination of paraparesis. One more time, thanks, Siobhan. A combination of paraparesis with a wide-based cerebellar gait. And her signs will be upper motor neuron signs of the legs and cerebellar signs throughout. Perfect.
Brilliant. Yeah.
This chart describes grading of muscle strength. This patient has abnormal strength of the right arm.
That little piece of paper and put it in. Good, if you can. That's pretty hard for that little piece of paper, isn't it? Okay, now can you move your thumb out? Okay. Can you squeeze down on my finger? Okay, good squeeze, as hard as you can, good. Now can you lift this hand up? And can you put it down And then lift it up again. And don't let me push down. Okay, that's good. Can you rotate this hand? Can you go the other direction? Okay, and pull it up. And keep it up and don't let me pull. And push it down. Push it down. Good. And bring this arm up like this to your up out. Don't let me push it down. Okay. Now this one, let's have you squeeze my finger tight. Good. And bring it up like this. Good.
This patient has abnormal strength of the right leg.
What I want you to do is I want you to just pull up on this leg. Just, don't let me push down. Good. And this side, don't push down. Good. And I want you to squeeze on my hands really tight. Don't push out. And pull out like this. Don't push in. Good. And straighten this leg all the way out. Don't let me push down. And this side, don't let me push down. Good. Now on your foot, can you lift this foot up?
No.
That's really hard.
Mm-hmm.
Okay. Can you push down? Hard to do that. Okay.
Mm-hmm.
Can you bring this over? Don't let me push out. Okay. And don't let me push in. A little bit more strength there. Okay. Can you bring your toes up at all?
No.
Okay. Let's do this side. Push down on my hand. Pull. Bring up your foot. Don't let me push down. Good. And bring your foot over here. Don't let me push down. And bring it out. Don't let me push over. Good. Okay.
This image describes the grading of reflexes. This video compares the deep tendon reflex of the patient's right and left sides and demonstrates clonus.
I'm going to tap over here. I'm going to tap on your ankle. Tap right here. Yeah, you can relax. A couple beats of clonus.
This video shows a Babinski reflex present on the right side of the patient.
Just try to relax. Very good. Okay. And then we're just going to do this one. Try not to pull back. All right.
This video shows a patient with abnormal pain sensation.
Is this sharp here any different than this sharp over here?
Yes.
Okay, what's different?
I can feel it better over here.
Okay, so that's different there than over here?
Yes.
How about here versus over here?
It's the same on both legs. I can feel it better over here than I can over here.
Okay, how about down here, over here versus over here?
It's sharper on this leg.
Sharper on this leg, okay, and it's the same wherever I touch then.
Mm-hmm.
And how about down on your foot? Any?
Mm-hmm. Sharper on the
Still
right.
sharper on this
Yes.
side, okay. And less sharp over here.
Yes.
Okay. If I were to do on your trunk, on your stomach, how about sharper here versus over here?
Sharper on the right side.
On the right side.
Mm-hmm.
Where does it change as far as?
It's right here.
Okay. And then as far as coming up, it would still feel
It's still the same.
same up into where we hit where?
Probably like right here.
About right there. Okay. So I'm just going to do that right here. Tell me where it changes, okay?
Mm-hmm. There.
Right about here?
And down a little further.
Right here?
Yeah.
Okay. And then it's sharper up here than it is down here?
Yeah.
This video shows an abnormal vibratory sense. We do want you to compare the patient's vibratory sense to your own by placing your fingers underneath the toe.
Down on your toes, is there any difference between that and this?
Yes.
What's different?
Not buzzing on this side.
You don't feel the buzz on this side. Okay. Okay, how about now? Hard?
Little. Yeah.
Okay. But over here, it's a lot?
Yeah.
This video demonstrates abnormal position sense in a patient.
I'm going to move your toe a little bit down, a little bit up. You close your eyes and tell me where I'm going.
Down. Up. Up. Down.
Now I'm going to move it.
Up.
Okay, now I'm going to move it.
Down.
Now I'm going to move it.
Up.
Okay, now.
Down.
Hold on, now I'm going to move it again.
Okay.
Okay, ready? Okay, which way?
Down.
Okay. Now tell me which way.
Up.
Okay, now tell me which way. I'm going to move it now.
Down.
Okay. Going to move it now.
Up.
Okay. Is it a little bit more difficult to tell this side?
Yeah.
Okay.
This video demonstrates a patient with abnormal graphesthesia.
I'm going to draw a number in your hand. You keep your eyes closed, and you tell me what number I'm drawing, okay?
3.
Good. I'm going to draw another number.
5.
Okay. I'm going to draw another number.
9.
Very good. And I'm going to draw one more number.
10.
Okay, and one more.
5.
Very good. Now we're going to draw it over here. Close your eyes. You just have to relax. Just total relax. And I'm going to draw the number, okay? Keep your eyes closed.
5.
No, no. Wait till I'm done.
9.
Okay. Going to draw another number.
4.
Okay. And I'm going to draw another number.
10.
Okay. And another number.
3.
And one more.
4.
Okay. I'm going to do one more.
9.
Good. And we're going to do one more.
10.
Okay.
This patient has an abnormal 2-point discrimination test.
Tell me if you feel 1 point or 2 points touching you.
1.
Okay. Tell me if you feel 1 or 2.
1.
1 or 2.
1.
I'm going to do another test now. I want you to tell me which points do you feel closer together. Do you feel these closer together? This is number 1. Or do these feel like they're closer together?
Come again.
Do those feel closer together? Or do these feel closer together?
The first one?
First one felt closer together. All right, do these feel closer together here? Or do these feel closer together?
Just that going.
All right, one more.
Though there is no volume in this video, note that when touched simultaneously, the patient neglects the stimulus on the right, but can correctly identify when touched on the right or left side. This patient has an abnormal finger tap and rapid alternating hand movements.
Can you just tap on one side just as fast as you can, and tap on the other side, and hold your arms like this, and just flex at the elbows. No, just like this. There you go. And I want you to just take one wrist and just rotate it back and forth, just one side, just back and forth. And the other side. And the other side again. And this other side. Okay? And now I want you just to pat front, back, front, back, front, back. And the other side.
This same patient has an abnormal finger-to-nose exam.
Just put the pin on, the cap on the pin. Okay, good. And now I'm going to hold the cap out here and you can put the pin on. Okay, and the other side, same thing. And then put the cap on the pen. Good. And now just go from the tip of your nose to the tip of the pen back and forth. And I'm going to move the pen. Okay. Good. Another hand. Good.
Again, this same patient has an abnormal heel to shin exam.
Hold your leg up like this. If you can just take this heel, start at your knee, go straight down and straight back up. Just with your heel. And then back up. Okay, let's do this side. I'll hold your leg and just go for your and then go down and then try to come back up too, slowly. Fine.
This patient is demonstrating an abnormal foot tap on the left side.
That's fine. Can you tap the ground with your left foot? Tap, 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 tap. And tap the other side.
In this video, Dr. Varghese demonstrates a few abnormal gaits.
I'm now going to demonstrate a couple of gaits. It would be a great shame for a patient to come to us with an abnormal gait and for us to send the patient for testing or consultation when the diagnosis might be fairly evident in the gait. The most common gait you'll see is the hemiplegic gait, and this is one that you see in hemiplegia where the arm is typically in this posture and the leg on the affected side is typically somewhat stiff, and they will then have a gait that looks something like this. And the characteristic of the gait is the circumduction of the foot. The fact that the foot is making a circle like that is what makes this gait so characteristic. If the condition is mild, the hand may not be flexed up like that, and the only manifestation might just be a little circumduction, and the hand may not be swinging normally the way the other hand swings. So that is called the hemiplegic gait. It's important to understand why they do what they do. When you cut the pyramidal tract on the left side, you have abnormalities of tone that manifest on the right side. So you develop flexion hypertonia in the upper limb and extensor hypertonia in the lower limb. And that accounts for the leg being like that and the hand being like this. In addition, they develop much more distal weakness than proximal weakness. Their shoulder is strong, the fingers are very weak, the thigh is strong, but the foot is weak, and so they have foot drop. And so the circumduction comes about because A, they have extensor hypertonia, so the leg is stiff. Otherwise, they could just step like this, you know, they could go like this. And B, because they have foot drop, because they have weakness distally, they can't lift up the leg and step like that, so they wind up circumducting. So this is the most common gait we will see around here probably. It's called the hemiplegic gait. Another gait that we would commonly identify is the gait of Parkinson's disease. It's a posture that's characterized by universal flexion. Every joint is flexed, and the patient typically will take very small steps. This is called a festinating gait. The French call it the marche à petits pas, the walk of little steps. And there might also be an associated tremor with the gait. The patient may have a myriad other abnormalities related to the Parkinson's that we're not going to cover in this session. Another gait that's very helpful to recognize, and it may be one that you're all familiar with from watching police videos and hopefully not from personal experience, is the cerebellar gait. The cerebellar gait is characterized by a broad stand and by a wide staggering quality to it. People will tend to fall towards the side of their illness, so if the illness is in the cerebellar hemisphere on the left, they might fall in that direction. When asked to stand still, their trunk may sway like this, and that is called titubation. And obviously they would have problems with all the other cerebellar tests. One caveat, many people think of the Romberg test as being a test of cerebellar disease. The Romberg test has nothing to do with the cerebellum. The cerebellar patient is already swaying, and it gets a lot worse when you have them close their eyes. But the Romberg test is really a test of proprioception. When you and I are standing like this with our eyes open, we are getting signals from our joints to tell us where we are in space. If, however, you have a problem with proprioception because of your peripheral nerves or posterior columns, then you're relying on your eyes to tell you where you are in space. And therefore, the moment you ask the patient to stand still and close their eyes, the patient begins to sway. And that is a positive Romberg test. It has very little to do with the cerebellum. Talking about proprioception leads me to the other gait related to proprioception. Once again, if you have trouble with your proprioception and cannot feel when your foot has arrived on the floor, you are relying on a lot of visual cues, and especially in the dark, you might develop what's called a stomping or stamping gait, where you tend to walk like this, needing to slam your foot down to get the vibration in your trunk to let you know that your foot has landed. So this gait may be much more prominent in the dark and not as evident in the daytime because they can see where they're going. A gait that we should mention in the context of the hemiplegic gait is the gait that's commonly seen in cerebral palsy. It's a diplegic gait, if you will, with hemiplegia on both sides, and it's a gait that I'm sure you've seen often in children and in adults affected by this from childhood. Typically, the patients have extensor spasm and almost seem to be walking on tiptoe, and although they have some circumduction, they have a lot of adductor spasm that keeps their feet close together. So they tend to be walking on tiptoe. The arm is flexed like this, and the adduction is a prominent feature. In fact, in some parts of the world where children do not get adductor releases, you might actually see a scissors gait, where the leg swings all the way over to the other side. And again, that is another manifestation of the diplegic gait. I want to talk about a gait that happens in people with myopathy, and this is a gait where the patient develops a waddle, and in order to understand this gait, you have to do a couple of things with me, if you don't mind. Put your hands on your hip, if you would, and appreciate that when you take a step forward, the hip on the side where you are stepping forward, that hip actually moves up. It moves up, and it's a function of having very strong pelvic girdle muscles that allow you to do that. If you have a myopathy, when you lift your leg up to take a step, because you can't hold your pelvis up and stabilize it, there's a tendency for the hip to fall on that side and for you to fall over. And to compensate for that, you lean your trunk this way. So you develop a waddling kind of gait, compensating for the fact that your pelvic muscles aren't strong. You get a waddling kind of gait, leaning away from the side where you have the weakness. In a sense, it's a manifestation also of the Trendelenburg sign. The Trendelenburg sign says that when you lift the hip on the affected side, the pelvis sags down, and it's a suggestion that you have weakness in the pelvic stabilizing muscles. Another gait that we'll discuss is the neuropathic gait. If you have a peripheral neuropathy and you have foot drop, then typically you have to have a high stepping gait, otherwise you will trip on your foot and fall forward. So patients with neuropathy, especially if it's bilateral, will have a gait like this, which is nicely also called the equine gait, or the stepping or steppage gait. And the reason they do this is they can't step forward without tripping on their foot, because they can't really dorsiflex their foot because of weakness. So the foot is weak, and so to overcome that weakness, they have to lift it up like so. The coriform gait does not, in my mind, strictly constitute a gait. These patients are already exhibiting writhing movements, involuntary movements when seated, and when they walk they can have the most bizarre sorts of gaits. And I don't think it's fair to call it a gait, because really the involuntary movement is manifest in pretty much everything they do. I would offer as a caveat that all our hospitals have long corridors, great opportunities to watch patients walking towards you, away from you, and I encourage you to make a habit of studying gaits as people come and go, and realize what a miracle it is for people to have a normal gait and how easily it is rendered abnormal by disease.
This patient demonstrates an abnormal Romberg test. This patient has a pronator drift on the left side.
Up, and then you just hold it there as long as you can. Close your eyes now. Close your eyes, and you just hold that there. You hold it there as long as you can. As long as you can. You hold that there. Hold it as long as you can. 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 You just hold it there as long as you can.
This child is demonstrating a positive Brzezinski's sign. This video demonstrates abnormal neurological findings in a patient with Huntington's disease.
Well, brother, thank you very much for coming. I really appreciate it. Now, brother has a form of chorea, so when looking at someone with an abnormal movement, you look for fine things such as tremor, physiological, which we all have. Then it can move on to an endocrine tremor such as thyrotoxicosis. It can be alcohol-related or alcohol withdrawal, other drugs. And then you move on to athetoid movements, which are more writhing movements. And you'll see with brother, the longer you observe someone, the more information you get. So sometimes silence is better than speaking all the time. With brother, he presented, what age were you, brother, when you first got abnormal movements?
About 50.
50. And is it rude to ask what age you are now?
64.
64. And
1995.
Oh, I see. Okay. And did you, have anybody in your family was affected by this?
Yes, the whole family.
The whole family were affected. Okay, so you were, what age did you say you were when it started?
50.
50. 50. And that was the first time you noticed. And what's the first thing you noticed?
I was slipping on the ground and falling.
Falling and
dropping things.
And dropping things. So falling, dropping things. And what was the first one? Shivering, was it? Shivering.
Or dribbling.
Dribbling. Sorry, dribbling.
Or dribbling.
Ah, sorry. Okay. Now, sometimes people with Huntington's have abnormal movements all the time. Sometimes they're less pronounced. And you have to watch closely to see this flexion extension of brother's back. He grinds his teeth quite a lot to try and overcome the orofacial chorea. Now, can you look at my finger here, please, and look up, and look down, and look right, and look left, all the way over to the door. That way. And to your right, head still. Well done. Left, right. I'm holding his head up high, look up high, and look down low. And there's a limitation as the condition goes on of eye movements. It's difficult enough to demonstrate, but abnormalities of saccadic eye movements or indeed progressive reduction in the range of eye movements can occur. Now, the other thing people notice is, can you open your mouth wide, brother, and stick out your tongue straight? Keep it out. Keep it out. Keep it out all the time. Don't let it back in. Come on. Keep it out as long as you can. But let's count to 3. Go. 1, 1, 1. Okay. And there's a difficulty with sustaining a movement. So as we see here with the right hand, if you don't mind, can you put your hand out straight in front of you, just your right for the moment, and close your eyes. Keep them there, and I want your eyes closed all the time. So hand out again. I'll kind of half support it here. Keep it there. And you can see the slightly writhing movements. Eyes closed when you can. I'm here now. Don't hurt yourself. Okay, now we try the left hand. If you put the hand out there, hold it there. Close your eyes, please. So they're quasi-purposeful is the phrase that people use, as if they're on-purpose movements. And they're generalized, affecting head to toe, generally the limbs more so than the head and neck. But in Brother's case, it is affecting head and neck. It's affecting his speech. Is your swallow affected?
Yes.
It is.
Very much so. I have to take things very easily.
You have to liquidize them?
Yeah, liquid.
Do you have to liquidize them? You do have to. Okay.
Huntington's disease.
Huntington's disease.
Is the sign. It's on.
Oh, I see. Okay. So Huntington's disease, that's one of the first signs for you?
Or no. For me, it was dripping on the ground.
It was
dripping.
Dripping on the ground. Dripping on the ground.
I went up out of interest to be dying to have a blood test.
So you had the test because your family were affected?
Yes.
And then you were told that you had the trinucleotide repeat, the triplet repeat. Yes. You're probably well read on this yourself, so it's not jargon to you. Okay, well that's fine. One last thing though, can you just try the hands again? I just want to see if I can accentuate it and close your eyes. I might cover your eyes, brother, because I know you have trouble keeping your eyes closed. If you don't mind, just hold it for a moment as best you can. If it's too much, let me know. Okay, that's fine, that's fine. Thank you very much. That's great. Well, brother, just look at me for a second. And can you just touch me with your right hand? That's fine. And I just want you to touch your nose with that finger. My finger? Touch my finger. Touch your nose. Touch your finger. Okay. That's fine. You're comfortable enough there? Good, good, good. And with your left hand, can you lift that up in the air and just hold it there? And touch your nose with your index finger of the left hand, sorry. Yeah, that's great. Maybe with your left foot. Can you lift it up like that? With your right foot, okay. And your left? Did you hurt yourself?
No.
No, okay. And can you cock up your foot like this? Look, just cock it up. That's it. And the other one? The left? This one? Cock it up and relax them. Just hold it there.
This video demonstrates abnormal neurological findings in a patient with Parkinson's disease.
Thank you for taking part in this. Can you tell me how long have you been having symptoms?
15 years.
About?
15 years approximately.
You've 15 years?
Yeah.
What age are you now?
30.
30. So you think it came on when you were a teenager, late teenage years?
Well, it was noticed by others.
Well, yeah, tell me about what you had noticed yourself.
It was getting slower and stiff.
And this had come on gradually over those years. When you were at college, did you notice it then?
I found it hard to write.
You found it hard to write then, yes. So when you were doing your leaving certificate exam, did you have any difficulty?
Not particularly.
No. So it was in college that you first noticed the problem with writing?
Yeah.
And in the summer jobs that you did, you used to work as?
I worked in the golf course.
The golf course during the summer?
Yeah.
When did you first notice difficulty on working on the golf course?
From the beginning, I suppose.
From the beginning. How long ago was that?
8 years.
8 years ago, yeah. Okay. So that's when you were about 22.
Yeah.
And what things have you difficulty doing now?
Tying buttons and...
Yeah, fine movements.
Yeah.
Can you manage the zip on your...
I can,
yeah.
Put on my socks.
Harder to put on your socks. Have you had any falls?
No.
No. Okay. Okay. So we're going just to have a look at some of the neurological symptoms and signs, just while you're sitting here, and then we'll go out and see you walking. Okay.
Okay.
Yeah. Patrick, can you just look at my finger and just follow it over? Yeah. Slowly. And look up and look down. So pursuit movement is slow, but and slightly slow. Look right over to the. But it is slower than my finger. Right. Look straight ahead, Patrick, and then can you look to the left and look to the right, and look up. Look up as far as you can. Look right up at the ceiling, yeah. And look down. Look right down at your toes. Or look at your hands. Okay, so we can do those fully. Can you just, we're just going to open your eyes slightly just to demonstrate this. So, and I'm just going to move your head slightly. And you can see that Patrick has, significant axial rigidity affecting particularly the neck muscles. It's very, very, very rigid. When you actually attempt to demonstrate the oculocephalic reflexes, just as we do this, difficult because he's so stiff, but you can see that he has what's called a positive doll's head reflex. And I'm going to go put your head back, Patrick, and then we're going to put it down. Okay, I'm going to do it. You just relax, okay? And you can see there particularly the positive oculocephalic reflex. I'll try and demonstrate it in looking down, but it's difficult in this situation. Just go right down. Yeah, okay. Fine. I'll just do it once more on rotation. Okay, that's fine. All right. Can you show me your teeth? Show me your teeth like this? Yeah, okay, all right. One of the signs that is useful to demonstrate is the glabellar tap sign. And this is due to a loss of habituation of the blink reflex. So one just taps the glabella repeatedly. And you can do it slowly. Some neurologists do it somewhat faster, like I'm doing it. But you can see the persistence of the blink reflex as long as you keep tapping. Normally, of course, this habituates, and if one tapped the glabella in someone who didn't have Parkinsonism, then the blink reflex would be lost. It wouldn't persist. One of the key cardinal signs of Parkinsonism is rigidity, and normally we test for this in the limbs. But the distribution of rigidity sometimes is useful in the diagnosis, and in some patients there can be quite marked axial rigidity. One tests for axial rigidity by passive movements of the neck muscles in particular. And in Patrick, I know, has quite marked axial rigidity, and it's very difficult to turn his head. There is quite marked resistance to passive movements. And I'll just attempt to demonstrate this. And I am trying to turn his head. This is not hurting Patrick, is it?
No.
No, okay. I'm trying to turn his head, rotating to left and right, and there is quite marked resistance. And I can feel that resistance. So I would call this quite marked, almost quite severe axial rigidity. When you look at the arms, there is, again, significant rigidity. Perhaps more marked on the left than the right, with resistance to passive movements. And there is a tendency to flexion. Can you put your hands together like that? And he can't really fully, you have to force them, and you can't really, he has developed a degree of some flexion contracture of the fingers. And really, as you can see, the prayer sign in a sense is positive in that he can't put his hands together like that. And can you do this for me, Patrick? And he's got marked reduction in rapid alternating movements. And can you play the piano? No. And do this here. What I want you to do is that. And you can see he's got really marked reduction in rapid alternating movements. And it is best to test in these 3 ways. Another way to test rapid alternating movements is to get him to do finger grips. Fast. Okay. Just to display the range of movements. There isn't any tremor as such of any significance. And you can see the posture of the hands. Can you touch my finger, Patrick, and touch your nose back and forward like this? And the other side, back and forward. And there's really no significant, apart from the slowness and execution, there's really no abnormality there. So I think we'll just see how you walk. Is that okay, Patrick? Yeah, thanks. And you can see that his gait is not bad at all, but you can see that he's not keeping his arms across his chest, and you can see the position of his hands. There's this symmetrical rigidity and abnormal posture. Just turn again and go back of his hands. So it's completely symmetrical, in fact. Come back for us again, Patrick. So this symmetrical akinesia, particularly of the upper limbs, with this abnormal posturing of the hands. Patrick, we're going to do that test we did before. It's called the pull test. I'm going to give you a jerk on your shoulders. I want you to resist. Don't let me pull you off your feet. Don't worry, I won't let you fall. Okay, but I'm going to give you a quick pull, and then we'll see what happens. Okay, so don't worry, I won't let anything happen to you. So just resist now. I'm giving you a pull now. You can see, yeah. Okay. So that was relatively a little pull. Normally, if that was a positive pull test, you notice the patient lost his postural stability and started to go backwards. That is called retropulsion. Sometimes you can demonstrate it in the forward manner as a propulsion. That was quite a small pull that I gave him. If the first pull hadn't been positive, I would have given a stronger pull. It's not necessary to do that because it's positive on the first. So that's a positive pull test. And that's evidence of postural instability, one of the cardinal signs of Parkinsonism. We'll try it in a forward position. Can you turn around to face me? Yeah. And we'll try again. So I just want you to resist me, Patrick. Okay, don't let me pull you forward. And then that's quite good. And we'll do just a good, quick one now again. Fine. And so it's negative in the forward position, but positive in the going backwards. Thanks very much, Patrick.
This concludes the clinical correlations for the neurological exam. What I presented in this video should be the beginnings of tying the clinical knowledge you are learning with the physical examination techniques you are practicing into the development of a differential diagnosis and how to start thinking like a clinician.